about the quiz, so I think that's a good sign. So that's pretty good. Any questions about the chemo stuff we did last week? Everything pretty much jive with what you learned in your other courses? Fantastic. Have you started neurology yet?
I start next week.
Okay, so we'll talk a little bit about Alzheimer's disease at the tail end of this, and then we'll also talk about seizures as kind of being the primary focus of this section here. And then there'll be like another neuro section next week. We'll cover things like Parkinson's disease and other things. So epilepsy, what is epilepsy? Having seizures. What's a seizure? Hmm?
So there's a very
Yeah, there's a lot of different types of seizures that are out there. Seizure can be hard to say if you're sleep deprived and you wake up in the morning. Okay, so there's some interruption of electrical activity. What would you kind of say, like if a patient didn't understand what a seizure was, like how would you, what other kind of health condition could you equate it to, essentially? We covered it last time, like cardio. So think about it. So electrolyte imbalances are really important. That can actually induce a seizure. But think about arrhythmias, right? Think about arrhythmias for the heart. Think about the same thing. And that kind of makes sense based on the type of drugs we're going to be looking at and their mechanisms. You remember with antiarrhythmics, what type of mechanisms do those drugs have? So just as an example. The different classifications, certainly calcium channel blockers, beta blockers. What was class 1 doing? Thinking back to the many months ago. So blocked a sodium channel, right? So it blocked sodium channels, and that's really important for not only myocyte conduction, but this is also really important for neuronal conduction. So we'll talk about that and how these mechanisms kind of make sense based on the drugs we're using. So anywho, so we're referring to this kind of abnormal behavior that's coming about from this abnormal discharges of these neurons. So basically the neurons are not firing appropriately in the correct order. I'm not going to get into the minutia of all the different types of seizures because that would take forever. I'm going to get into the most common drugs we're using in order to treat these. Basically epilepsy is just the syndrome of having a seizure disorder. And then the big one we deal with, especially most in the emergency department, is status epilepticus. So that's basically where a patient has kind of recurrent seizures to the point where they don't really get back to their baseline mental status, right? So anyone know what you call it after a patient has a seizure? That there's a period they have. Post-ictal, yeah. So there's a post-ictal period where they're not having a seizure, but they're not really with it yet. They may not be able to communicate super appropriately. They seem kind of drunk, if anything. But basically, if they never get back to their kind of baseline status before having another seizure, that's called status epilepticus, and that's a neurologic emergency. Why do we care about a patient having status epilepticus? They may not be breathing appropriately, right? So they may aspirate, they may get fluid down in the lungs. All kinds of problems can happen here. And so that's why there's a lot of, it's a very common thing you run to the emergency department. You get very good at treating it. We'll talk about some of the main drugs we use for that. So anywho, there's lots of different etiologies of seizures. So the ones that I deal with most from the tox standpoint are usually going to be due to drug use. And so we see a lot of things where antidepressants can do this with some frequency. And remember how we said with antiarrhythmics, any antiarrhythmic can cause arrhythmias. Very similarly, these anti-seizure drugs can actually cause seizures, especially if they're in too high of a dose. And so for some of these, we'll actually do what we call therapeutic drug monitoring. When you guys remember what that is? Yeah, you're looking at that therapeutic window. You're measuring blood levels to make sure the drug's staying in the right range. Because again, they get too low, they have a seizure. It gets too high, they could also potentially have a seizure. That's one of your things when you're evaluating a patient coming in. Was their drug level okay? Was it too high? Was it too low? That may influence your decision on how to, kind of further proceed. Now, when you think about things like alcohol, imagine what does someone look like when they drink too much alcohol? They're a little CNS depressed. They may be passed out. Does that seem like someone who's going to have a seizure? Not really, right? Their neurons, if anything, are very slowed down. The problem is when you have withdrawal from alcohol, that's where you can have a common precipitant of seizures. If you have an alcoholic, maybe they run out of money, they don't have any way to get access to alcohol, all of a sudden now they're having withdrawal seizures. So again, you have to think about, there's a wide variety of things that can cause seizures, and so it's important to have a good wide differential when you're considering these patients. But other things, CNS infections like meningitis can be another common one. Hyperventilation can cause head trauma, lots of different things. But you're going to see a lot of the treatment is going to be very similar. We'll talk about a few examples where you're going to have specific drugs for a specific type of seizure, but by and large, you're going to find that a lot of these drugs have kind of a wide range of activity treating various different types of seizures. Now, again, these are going to be occurring because we're having this kind of abnormal repeated firing of the neurons, and so what we want to do is to try to inhibit that. We want to make sure that we're achieving this kind of normal membrane conductance, and these inhibitory currents are happening here. So again, they're too excitatory, they're going to be firing off too frequently. That's what's causing the seizure. So we have both things that can inhibit that. So we have things like GABA. Anyone heard of GABA before? I mentioned it. Probably have mentioned alluded to it previously. This is the main inhibitory neurotransmitters. This is the main thing that's going to help to increase the threshold that it takes for a neuron to actually fire off an action potential. If you increase that threshold, it makes it harder to have an action potential. You can inhibit that, and that's the same way that things like alcohol is working. They're actually working very similar to GABA or enhancing the effect of GABA. On the flip side of that, we have glutamate. This is the primary excitatory neurotransmitter. So if you think about GABA as being the brakes on the system, glutamate is the gas. You have too much gas on the system, you're going to cause the action potential to fire off too quickly or too frequently, and that's what causes a seizure. So you can end up having issues on kind of either side of the equation there. And so, and what kind of things can affect that resting membrane potential for those neurons they're kind of sitting at? So very similar to what we think about with the heart. Electrolytes are going to be super important here. So that's why you can have big shifts in electrolytes can cause seizures, especially with sodium. Sodium is super, super important for maintaining a resting membrane potential. And that's another potential thing we see, especially not nowadays and when it's unseasonably cold right now. But think about the summertime. Think about someone who is, they want to get into shape. They're going to go to these boot camps and they get super dehydrated and they lose a lot of sodium through their through their sweat, I should say. They can end up coming with seizures. So lots of different varieties here, but we'll see that electrolytes are very, very important for this. So imagine that you have your neuron here. It's going to be firing off down the axon, and basically you have these action potentials that can jump from kind of point to point here, right? Those nodes of Ranvier, if you remember back to your physiology and all of that. But basically, the sodium conductance here is very, very important for this to occur. Notice this is also an ATP-dependent process here. Remember that transporter that helped to reset the resting membrane potential, that sodium potassium ATPase pump. Remember, that still kind of rears its ugly head. Not only does it reside in the heart, it kind of resides everywhere, but you find it here in the neurons as well. So this is very, very important. And remember, it requires ATP because it's pumping against that concentration gradient. So anywho, so you may see, like in someone who has a seizure disorder, maybe they have a lowered activity of this pump. Maybe if you were to inhibit that, you could see some altered conduction disturbances. You can see that resting membrane potential change there. The other big thing is, you guys remember refractory periods? We talked about that with the heart. What is a refractory period? Yeah, it's that period of time where it doesn't matter what kind of extra signal you send along the way, it's not going to be able to trigger another action potential. So again, there's that absolute versus a relative refractory period, very similar to how the antiarrhythmics help to extend out those refractory periods to try to prevent an aberrant arrhythmia from coming along and sending off another action potential. The same thing's happening here, basically, where that resting membrane potential has a big effect on those refractory periods. So when you're trying to make a diagnosis for a patient, lots of things come into play here. One of the big things you want to do as far as history goes is one, family history is important. You also want to look at things like the medications that they're taking, because this could be a common precipitant to them having a seizure. So for instance, I mentioned bupropion. It's a very common antidepressant. That one can be a big one that not a lot of people think about. But lots of medications can do this, not only legal drugs, but also illegal drugs, right? So you think of any drugs that can cause seizures, like illicit substances? Not that you would ever do any of them, but Molly. Anyone know another name for Molly? Yeah, so MDMA is another name for that one. So like ecstasy, that can be a very common one. So a lot of your stimulant type drugs. So amphetamines, cocaine can do this. A lot of stimulants. If you think about it, it makes sense based on, if you imagine alcohol kind of being the opposite side of that. Alcohol being a very inhibitory type of drug. The stimulants can definitely cause seizures in and of themselves based on these activities here. So anyway, not to get too into depth on that, but again, you may not find a lot of physical exam findings when you're dealing with someone with a seizure, but certainly things like labs, to look for things like electrolytes. You can look for toxicology screens, potentially could be of some utility there. And then obviously things like MRIs and EEGs can be very, very useful in trying to help you with this diagnosis. Again, I'm not going to get super in depth on that, but I do want to talk about the treatment goals here. So ideally, we'd like to have no seizures for your patient. And seizures are tough, Because again, when you have a patient you're treating, the question is, well, okay, so I started you on this new drug, and I'm seeing you again in 6 weeks. You come back and you haven't had any seizures. The question is, if you had no drugs on board, would the patient have had a seizure during that time? Hard to say, right? It's kind of like the elephant repellent. Like, is the elephant repellent works really great. There's no elephants here. Well, who's to say there would have been elephants in the first place, right? Analogy makes sense? Maybe. Okay, anywho. So again, it's one of those things where it's like you don't really know. You have to kind of wait until another seizure occurs to see just how effective it's going to be. But ideally, we'd like to have no seizures, no side effects. Side effects are a big problem in a lot of these drugs, as we'll see here. Obviously, addressing things like patient concerns and comorbidities, and then also just kind of affecting their quality of life. Because no one likes to have a seizure. It's kind of a big interruption to their day, their daily routine. So we'd like to prevent that if possible. So some characteristics to consider about your patient. Age can be really, really important for some of these drugs. They can affect the pharmacokinetics, as you'll see in one of the prescription writing questions we have if you go back and look at that. For example, phenytoin is a very common antiarrhythmic, less common nowadays, but it used to be kind of one of the mainstays of therapy here. You'll notice that the dosage range actually changes based on the age of the patient. So again, if you're dealing with a 6-month-old patient up to 3 years, you dose it between 8 to 10 milligrams per kilogram per day. However, when you get to a little bit older patients, say you're going down to 7.5 to 9, 7 to 8, 6 to 7 for an adolescent or teenage patient, why do you think this change occurs? Well, because we're doing it on a milligram per kilogram basis, so weight really shouldn't have a factor here, right? Yeah, metabolism is going to be a big thing. Body surface area probably not a big influence here, but the metabolism is a big thing that changes. If you guys go back to some of the kind of the intro course lecture, you'll realize that with pediatric patients, in general, when they're born, they have kind of underdeveloped function of a lot of those liver metabolizing enzymes, and some of them actually end up getting kind of upregulated higher than it would be if they were an adult patient. So those things we've already kind of done the science on, we've done the research, and this is where these recommendations come from. We know that a patient who's a year old is going to be metabolizing phenytoin faster than someone who's going to be, say, 12. And so because of that, it's important to make sure that you're adjusting based on that, because otherwise if you kept dosing a patient, say 10 milligrams per kilogram per day up through the time that they're a teenager, because again, our seizure disorders is something you kind of grow out of. Not routinely, right? It's one of those things where you may have to treat them for a lifetime, right? It's one of those things where if you kept using that same 10 milligrams per kilogram, you kept adjusting for weight, but not adjusting for the age of the patient, you could run into problems and they end up getting overly sedated due to their dose being too high. Okay, so just things to consider. Again, other medical conditions can have influences here. Their ability to actually comply with the medical regimen is really important. Some patients require multiple drugs in order to control their seizures, and if they're not able to keep up with this can be an issue. Also, we'll talk about side effects, but one of the main things you see with these drugs is sedation is a big side effect. And when you're sedated, you remember to take things like your medication like you should. That can be a problem, right? So this is one of those things to always consider. And then also insurance coverage. There's a lot of newer drugs that are starting to come out, which is all well and good. Some of them may be very effective for very difficult to treat seizures, but if the patient can't pay for it, they're not going to take it, right? I'm going to cover kind of the mainstay drugs that we see most commonly. I'm not going to cover a lot of the newer ones coming out, but just be aware you may see some other ones, but they follow a lot of the same principles we're kind of looking at here as far as their mechanism. So just keep that in mind. So question is, did a seizure actually occur? You say you find someone who had a syncopal episode, you find them on the ground. The question is, well, how did they end up like that? Was it an arrhythmia? Was it a seizure? You kind of do that workup. If a seizure did happen, if you're kind of confident in that, what type of seizure was it? So for instance, with pediatrics, we deal with this very frequently, especially in small babies. They end up having what type of seizures? Anyone know? Febrile seizures, right? So again, that is something that is very different mechanistically than an actual true blue seizure disorder, and so we don't treat them the same. So you have to kind of figure out what type it is to deal with that. If it is a seizure that you can treat with drugs, what type of pharmacotherapy we're going to use, what drug is most appropriate, and then the monitoring is super important here as well, right? Not only for side effects, but also for things like blood dyscrasias that can occur. And we'll talk about some of those as we get into more detail here in just a few minutes. So anywho, with antiepileptic drugs, right, AEDs, you'll see them abbreviated sometimes, a lot of patients are maintained well with just one drug, which is great. A lot of patients, though, may not be able to tolerate that. They may still have breakthrough seizures despite drugs being maximally dosed, and so you may need to use multiple drugs. And so I've seen some patients be on 3, 4, 5 different medications to control their seizures. A lot of these are like, at least in my realm, I see a lot of these young kids who have very either some sort of kind of congenital issue, some sort of actual, structural damage done to the brain that is leading them to have these seizures. We see this a lot, especially with kids who have anoxic brain injury, right? So that can be a really, really big problem. So imagine someone who had maybe like a non-accidental trauma, or they had some other issue that occurred where they have anoxic brain injury. Those kids have had a lot of damage done to those neurons, very similar to how you have a heart attack. You're more likely to have arrhythmias afterward due to that damaged tissue. Same thing happens in the brain, right? So these kids require a lot of drugs in order to help keep these seizures under control. And then we'll have other things like vagal nerve stimulators can help with this, surgery, and sometimes you can actually have, just like you might ablate a part of the heart in order to help get rid of a problematic area causing arrhythmia. Sometimes you can do that in the brain. And then, has anyone ever heard of a ketogenic diet? What is that? Yeah, so similar to the Atkins diet, right? Atkins diet is a very low carb diet. The idea is you want to have your body primarily trying to get energy from things like fats and proteins rather than carbohydrates. This puts your body into a state of ketosis. And anyone know what happens to the pH of the body in ketosis? Because remember with diabetics, they get diabetic ketoacidosis. So you typically get more acidotic when this occurs. And so we have kids where we find that with the brain tends to have a harder time having a seizure when you're more acidotic. It helps to make those action potentials harder to fire off, makes that threshold higher. And so for some patients we have, and we see this more frequently in kids, I think, than adults, they get put on these ketogenic diets, very, very low carb diet, very, very few carbs, in order to make sure they get lots of fat, lots of protein, and it helps them maintain this acidosis. It's a mild acidosis, not as bad as a DKA patient, who's a diabetic, but it is important to help them maintain that threshold, make sure they don't have a seizure. And the reason why this is so important for us is because when you come in, and kids oftentimes, can they take large pills? No, we have to use a lot of suspensions, and a lot of those suspensions, in order to make it palatable, we put a lot of sugar in there, right? And so we have to make sure we're using sugar-free varieties of drugs if they're available. If not, we have to custom compound things. And so from a pharmaceutical standpoint, it's very, very important. And from your guys' standpoint, education, like, okay, what kind of foods can they have? What type of drugs should they avoid? Things like that, and make sure they maintain that acidosis. Yes, ma'am.
Can't long-standing acidosis make their seizures worse, or the drugs kind of?
It's mild enough where I don't think they have like any long-standing issues. But again, if you talk to a neurologist, they might have a different opinion on the matter. We just see it from our perspective in the pharmacy where we have these kids, and it's interesting because the way that we signal, because that's kind of it's a medical error if you screwed that up and gave them the wrong variety of drug that had sugar in it, right? Because you can throw them out of ketosis and then they have a seizure, right? And that's on you. So one of the things we actually do is we'll put it up in their allergies. Actually, they have a sugar allergy, right? No one actually has a sugar allergy, at least not that I'm aware of. Maybe different types of sugars, but actually like dextrose allergy, not really. But that's one of the things that alerts us to know that, okay, hey, this kid's probably a ketogenic diet kid. We need to make sure we're subbing out their meds to make sure they don't have any sugar in them, right? So anyway, so kind of determining our optimal therapy is to, one, look at the type of seizure, how frequently they're having it. Obviously, patient goals are important here, and then drug interactions are huge, especially when you're looking at not only comorbid conditions, but if you're mixing different anti-epileptic drugs together, drug interaction are going to be huge. We'll look at that. Adverse reactions, mechanism, and the follow-up and monitoring is very important here, and then we'll talk about compliance and cost. Okay. So ideally, we like to start with monotherapy. If you can just use one drug, that's going to be ideal for most patients. And then if you cannot get good seizure control, you can monitor levels for certain drugs, and if those are still appropriate, then you can add on an additional drug. And then at that point, if you're kind of having multiple failed therapies, this is where you can start to think about things like nerve stimulators, ketogenic diet, etc. Okay. Generally with these drugs, because of their side effect profile, we generally want to start low and titrate up. Again, it's hard to say, if you had a patient who was seizure-free for 6 months, like, was it actually because you would have been seizure-free regardless, or is it actually the drugs we're dealing with? So that's why we like to start low. We can always give more drug. We can't necessarily take it back, right? So again, if they start at low dose and they're still having seizures, bump up the dose, right? But it's harder to back off from those the doses once they've kind of found to be effective. Again, we may need to do that therapy to drug monitoring. I'm not going to have you guys memorize levels or anything like that for this test, but I'll talk about different examples where we'll do therapy to drug monitoring. So just be aware of that. you may need to change drugs. The drug may be super effective, but if they're having kind of intolerable side effects, it may need to switch off of it. So that's something you may also need to consider. And then if one type of drug, based on one mechanism, is not effective, you may want to consider using a drug with a different mechanism. So that's why it's important to have that in mind with different mechanisms these drugs are using. So that way when you're adding multiple drugs together or you're switching from one drug to another, you make sure you're not going to have any kind of duplications or thing that doesn't make sense. So if I have one sodium channel blocker on board, it doesn't really make sense to add on another sodium channel blocker. It makes sense to use something else that may work through a different mechanism. Okay. So we're going to talk about these main groups. Probably only going to focus on the sodium channel blockers, calcium, the GABA enhancers, glutamate blockers. These are some other ones that are kind of more miscellaneous drugs. You guys remember we talked about carbonic anhydrase inhibitors? Where we talked about those at? The eyes. Yep, we talked about them for use for glaucoma, right? So remember like dorzolamide, brinzolamide. Anyone, you remember where else we used them?
For diuretic.
As a diuretic, yeah. So remember, acetazolamide is kind of the common one we use as a diuretic. Just remember, if you inhibit carbonic anhydrase, the reason why that causes a diuretic effect is that you actually would end up secreting bicarb, right? That would actually cause a little bit of a metabolic acidosis, right? Because you're peeing out bicarbonate. That kind of makes sense based on what we know about ketogenic diets. So if you increase the hydrogen ion concentration, if you lower the pH, that makes that seizure threshold a little bit higher. It's not a commonly used set of drugs, but it is one mechanism you can consider. And then the actual hormones can play a role here. So you may find that, especially with younger patients, if you start them up on things like oral contraceptives, it may make some patients' seizures worse, may make some patients' seizures better. I'm not going to super in detail on these, but just know that these are possible therapies you may not necessarily consider as an antiepileptic. And there's some drugs we just don't know how they work. We're like, I don't know, they work. Worked in the mice, given to humans, they work. Okay, we're just going to stick with it, right? So anyway, so looking at the different targets for the ones that at least the drugs we do know how they work. You guys remember covering in these graphs before, right? So this is kind of a resting membrane potential for our neuron here. Remember that you have to have some sort of threshold come along, some stimulus, usually another action potential from another neuron. Or it could be, say this is like one node of Ranvier, say down the axon, here's another node of Ranvier that's sending an action potential. Basically what this is doing is opening up these sodium channels that causes a large increase in potential here, right? And this is where eventually you're going to have potassium channels close, and then you're going to have a resetting of this repolarization that occurs here. Remember, sodium channels are closed at this point. And the main thing that helps maintain this resting membrane potential is that sodium-potassium pump. Remember, we are going against the concentration gradient. We're going to be sending potassium into the cell. We're going to be sending sodium out of the cell, and that is what helps maintain this resting membrane potential here. But the big thing we're going to see is that if you block these sodium channels, one, you can actually help to decrease the actual the peak of this potential here. The other thing you may do is actually prevent the action potential and occurring in the first place, right? So that can be very useful. Remember, just like in the heart, we had 3 different resting states for sodium channels. We're not going to get super into detail on these. Just know that they exist, and different drugs will affect different states of that sodium channel. So you may see a little bit of different activity there. So if you imagine things, sodium coming in here, if I could just have a drug that can block this channel, that's going to be helpful to blunting that increase in potential. It's going to be able to helpfully help blunt that action potential from occurring in the first place, and that can help to prevent a seizure from happening. So we'll talk about the individual drugs here in just a little bit, but just if you can reference back to this when you're looking at the individual drugs and their mechanism. So we can also deal with calcium channels. So this is more important here for, we're dealing with different calcium channels than we will deal with for the heart. Remember, we're dealing with the L-type calcium channels primarily for the heart. That's where things like verapamil and diltiazem primarily work. We're dealing with different types here, predominantly the T-type calcium channels. And so this is actually a good one. So you guys ever heard of absence seizures? So you think about like a typical grand mal seizure, like a tonic-clonic seizure. Like how do those patients kind of look? You have a lot of the jerking, like they have loss of consciousness, but there's lots of different varieties of seizures that are out there. The other one, another one you'll run into is some regular, it's called an absence seizure. Anyone know what that looks like? I just had one, right? So it's one of the things that, yeah, basically kind of stare off, it could last for, indeterminate amount of time, but basically usually pretty quick. They'll kind of stare off into space, and they'll come right back to wherever they were before. So that is a different mechanism of seizure, and so we'll find that there's a different drug that we actually use for that. So kind of keep this ethosuximide in the back of your mind. That's an important correlation between absence seizure and ethosuximide. We'll see in a little bit. But just know, by affecting calcium channels, we can affect that action potential, hopefully blunt that, and prevent the seizure from occurring. Yes, I believe it can be also called a petit mal seizure. You don't usually hear that terminology a lot anymore. Like grand mal seizure, you don't hear a lot either. Usually it's like tonic-clonic, absence. Yeah, it's the kind of the more common things we hear nowadays. So that's what they're referring to it. Yeah, when they have like a petit mal seizure. Yeah. So I always joked a lot of my students have absence seizures during my lectures. Just kind of staring off in space. It's about a 2-hour long absence seizure. I'm very concerned for you guys, but probably give everyone like Ethosuximide beforehand. Huh? Yeah, exactly. Because you weren't listening because you had an absence seizure. There you go. See? Anywho, right, so again, very similar to what we see with the sodium channels. There's less to do with like inactivated versus active states, things like that. But just know by blocking these these calcium channels here, and again, different drugs are going to work on these different sites, you can hopefully blunt that action potential. All right, so this is another big category. So we have GABA here. We have two different main types of GABA receptors. We have GABA A and GABA B. The main thing we're going to focus on as far from a neurology standpoint is going to be GABA A receptors. GABA B is really important, but they have different effects, and we see a lot of GABA B activity for things like antispasmodics or like muscle relaxant type drugs. So if you guys ever heard of like Flexeril, that's a very common one that affects GABA B. We're focused on GABA A though, and so basically when you open up a GABA channel, it being inhibitory, what ion do you think is letting flow through? So to cause an active potential, we let sodium flow through, right? That causes a big increase in potential. What do you think, GABA being inhibitory, what do you think that would let through? Not a positive charge ion, right? Because sodium is a positive. That causes an increase in potential. We let something negative flow through, right? Most common negative ion? Chloride, right? So this is a big thing where you have chloride flowing in. This does the opposite effect of what sodium does. By opening up those channels, you allow for more chloride to flow in. That potential gets more negative. You're driving down that resting membrane potential, and you make it harder for that stimulus to cause an action potential to occur, right? That's the main thing to consider here. And again, if you lose this GABA activity, the main thing you see is going to be seizures because, again, the resting membrane potential is too high. You're too likely to have a seizure, likely to have an action potential occur. That threshold is much lower. That makes sense? All right. So we can affect GABA neurons in several ways. So one, we can actually make the channel work more quickly or to work more often, right, to actually open up and allow more chloride to flow through. The other things we can do is actually change how the body's handling GABA, right? And so neurotransmitter metabolism is a very important way we can do this. So for instance, we can modulate this enzyme called glutamic acid decarboxylase. And this is actually by changing this, we can actually allow for an increased amount of GABA to be available to be released from the neuron. I'll show you a picture of this in just a second. The other things we can do are going to be things like blocking the reuptake of GABA so that more of it's going to be stuck out in the synapse. So more of it's left out in the synapse, more of it's going to be available to affect those GABA channels, right, as we'll see in just a second here. So we can also do things like affecting the metabolism of GABA. So there's another enzyme called GABA transaminase. This is responsible for cleaving GABA so that it can be eventually recycled. But we can affect that, and by inhibiting it, you can have increased amounts of GABA available. And then the primary thing we're going to look at for our purposes, more common things we'll run into are drugs that bind to these kind of allosteric sites on the channel to allow GABA to work better. And this will make more sense when we look at the picture. Okay, so imagine you have your GABA channels here, right? So basically you're going to have, normally GABA will come in and bind to these binding sites and will allow for the channel to open, chloride flows through, you drive down that resting membrane potential, the neuron's more difficult to fire, right? Those allosteric sites I was talking about are just drugs that can bind to different sites on the receptor to allow GABA to work better. Basically, it changes the conformation, allows GABA to bind a little bit more easily. This is where we run into drugs like our barbiturates. Anyone know of a barbiturate? Fiorset contains a barbiturate, absolutely. So that's butalbital is in that drug. Everyone ever heard of phenobarbital? That's a big one, right? Or pentobarbital is another common one. So we'll talk about the barbiturates that affect that. And then the other big group is going to be the benzodiazepines. Anyone know of any benzodiazepines? Heard of these? I've never heard of like Ativan or Versed or Xanax. Those are all benzodiazepines, and they're basically going to make GABA work better. Imagine very similar to alcohol. Someone who's on a benzodiazepine, they usually look pretty sedate. And so again, we'll find that those are going to be some of our go-to drugs that we actually use to treat active seizures in just a little bit. So those are the most common ways to affect GABA, but there are other drugs that can, one, affect, say, glutamic acid transaminase. This is one of the things that's responsible for metabolism of GABA. I'm sorry, GABA T right here. This is actually the GABA transporter. So if we can block this transporter here, you leave more GABA out in the synapse to interact with the receptor. So that kind of makes sense. And then other things actually affect how we actually are metabolizing and producing more GABA. So again, we'll kind of go through and look at the more common drugs we're going to use, but you're going to see that this is a very common set here. The benzos and the barbs are going to be very important for treating kind of acute seizures. And then we'll see that some of these other drugs can be used to help kind of maintain and hopefully prevent seizures. So kind of similar to what we're looking at with asthma. Remember we had like acute treatment medication, and we have medication that was better for kind of prevention of asthma attacks. Very similar to this here, where you may have some drugs that are useful for acute treatment of seizures, and then some drugs that are better for kind of long-term maintenance to prevent seizures from occurring. Same kind of modality here. So, and then the other receptor that's really important here is going to be the glutamate receptor. We primarily said that GABA is inhibitory, glutamate is going to be excitatory. So if we can block those channels, typically you're going to see a decreasing amount of seizure activity that happens here. This is important because when glutamate binds, it's going to cause inward flux of things like sodium and calcium, and because those are positive ions, we know that's going to help to lead to the action potentials to fire off more readily, right? So that's important there. And then also may see some affecting things like potassium flow, but just know that they're typically excitatory. There's a couple different receptor types that are available. I'm not going to have you know specifically which glutamate receptor, which drug affects. Just know that glutamate is going to be primarily excitatory, but by affecting different receptors, you can get different activities. So for instance, anyone ever heard of an NMDA receptor? So if you block NMDA, this is actually what we do with the drug ketamine. I'm sure I've mentioned that drug before. Ketamine is a good sedative, but it's a dissociative sort of anesthetic. So there's some other drugs that do that as well, but ketamine is one of the primary ones we use in medicine. But again, you can cause a very kind of interesting sort of dissociative sort of anesthesia by blocking these receptors. But just know these are going to be excitatory. I'm not going to get super granular on the actual receptor types on the test. So, but you'll see that different drugs work at different ones. So for instance, the NMDA receptor, you see things like Levetiracetam, which is a very common one we'll talk about a little bit later. And then also like the amphokinate, topiramate. Anyone ever heard of Topamax before? Topamax is interesting because it actually gets a lot of use off-label, not just for seizures, but anyone else know what else we use? Yeah, so we use Topamax for migraines occasionally. Anyone know anything else? Some people try to use it for weight loss before, so there's a lot of off indication use for topiramate. But again, it's working at these glutamate receptors. Okay, so just know that by blocking these different types, you can block inward flow of positive ions. This will help to prevent the seizures from occurring by blocking those action potentials. So I don't want to get more into detail than that. Okay, so just briefly, things like progesterone and estrogen can play a role here. I'm not going to talk about specific drugs that can manage this, but just know that in some cases, estrogen and progestins can worsen some of the seizure activity. Sometimes they can actually help. So it just depends on the patient, kind of what their predilections happen to be. And then we don't really use carbonic anhydrase inhibitors much, but you will see them occasionally as a diuretic. More often, though, we see a lot for glaucoma. Okay, so this is not an all-exhaustive list, and just know I'm going to use the most common agents that we see used clinically, but you will also see some of these being used for other indications as well. So we'll talk about those kind of as they come up, but a lot of these you can see sometimes being used for bipolar disorder, because these can act as a mood stabilizer, and then some of these are going to be used for neuropathic pain. So we haven't talked about pain stuff yet. We'll get to that probably in the next section, I believe. But neuropathic pain has a different mechanism than typical like somatic pain, and so we treat that differently with some of these drugs. I do love like I knew one professor who made people when they walked in late sing I'm a little teapot. I said, no, I will never do that. That is too draconian for my taste. Anyway, I just made the test harder if that happens. Just kidding. Just kidding. I don't do that. I think we believe you. Don't believe me. Just joking. Anyway, all right. Any questions on the first half? Now we're getting to dig into the actual drugs themselves. So the first one we have phenytoin. Phenytoin is a staple of anti-epileptic therapy. This is the primary thing we're going to use in a lot of cases. A lot of go-to as a go-to drug in a lot of cases. It's starting to take kind of a backseat in respects to our go-to drug for things like status epilepticus. I'll talk about which is kind of replacing it a little bit later, but you'll see this used quite frequently. The main way this is working is by blocking those sodium channels. So this is primarily a sodium channel blocker. Block sodium channels, prevent the action potential, prevent the seizures from propagating. Now, the problem with phenytoin, why we don't like to use it routinely for either main treatment for seizures or kind of maintenance therapy, is there's a lot of issues with it. So for one thing, it's highly protein bound. It's about 90% protein bound. And why is that a problem? Why could that be a problem? So if I were to say do something to where I increase that fraction of drug that's unbound to the protein, what could that cause? Because we said if a drug is bound to a protein, is it active or inactive? It's inactive, right? Because it's bound to albumin, it can't interact with those receptors. But if I were to say increase that fraction, say I went from 10% to say 20%, now that free fraction of drug is a lot higher. Guess what? A lot more risk for side effects. Yeah, so we'll talk about free levels in just a little bit, but that is a very, very important thing. This is very important, especially for patients who have altered serum protein. So you imagine someone who has liver dysfunction, long-standing liver dysfunction, they don't make a whole lot of albumin, right? Or someone who has nutritional deficits for a long period of time, they don't make a whole lot of albumin. So because of that, you can actually pretty strongly affect that and change that fraction that is actually available to interact with those receptors. So other things, that is metabolized, and you'll see a lot of these drugs that we use to treat seizures are mainly going to be hepatically metabolized. So that's where a lot of the drug interactions come from. So for instance, phenytoin is metabolized by CYP2C9, 2C19. Those are the most common ones. If you guys remember back when we talked about warfarin, that is also another big one that got metabolized by 2C9 and 2C19. But the main thing here, this actually induces CYP3A4 and 2C9 families, and also that PGP protein. That's less important here. But we're mainly focusing on the CYP enzyme. So when they induce that, why could that be a problem? If I induce the enzyme, what could that do to levels of other drugs that get metabolized by those enzymes? They decrease, right? So you may find other drugs to be less effective, especially if there are other antiepileptics that are on board that get metabolized to those enzymes. That's another thing to consider there. And so you're going to find that these are has a wide variety of utility here in treating not only just partial seizures, but also generalized seizures. Use it for lots of different things. Not typically for absence. We'll talk about one drug in particular we use for absence seizures, but in general, most of the other drugs have a kind of a wide utility. You can use them for lots of different seizure types. So similar to the cancer thing, don't get hung up on which specific types of seizures these can treat, except for this one example I'll talk about later on. I'll make that pretty abundantly clear. So I'll talk more about some of the kind of common side effects with anti-epileptic drugs a little bit later on, but main thing you're going to see with these drugs is going to be sedation, right? Because again, we're slowing down those neurons, we're trying to prevent them from having action potentials. Sedation is a big side effect. So you see a lot of lethargy, a lot of blurred vision, and that can be alleviated by starting with lower doses and gently titrating up. And patients will get used to this to some degree over a period of time. So again, there is some degree of adaptation that occurs there, some degree of tolerance that happens, and that's important. Other things you may find, things like hirsutism, gingival hyperplasia can be a common adverse drug reaction. Again, other reasons that may not be, terrible in the patient's overall, health, but can decrease their quality of life, right? So again, if their gums are starting to kind of grow out of control, the hirsutism can be pretty problematic for a lot of patients. So just so you know, we have, this is one of the ones that we can use for acute seizure management, because we can use this one IV. The problem with phenytoin, though, it doesn't like to go in solution, and so we have to use another version of it. And so we actually have another drug called phosphenytoin, or Cerebex. And this is actually just basically a phosphate group added onto the drug that has to get cleaved off, and then you basically have phenytoin again. And so this one we like to use more for parenteral administration. It's more water soluble, goes into solution better, not so hard on the veins. This is another one that can be a very, very bad vesicant. Phenytoin itself, the parent drug, if this extravasates out of the veins, this can cause what we call purple glove syndrome, where basically all of the tissue in the hand can start to necrose and can slough off. So there's been a lot of malpractice suits that have been made because of that, because people were not giving phenytoin appropriately. They're either too quick or at too high concentration. So this is the nice thing with phosphenytoin. It's much more water soluble, much easier on the veins. You don't have to worry about that quite so much. Yes, ma'am.
So you said phenytoin isn't soluble well, so that's given PO.
So we use it at PO quite frequently, but there are ways we can get into solution. So kind of outside of our scope here, but one of the things we can do is like alter the pH of the solution. We can add in things like solvents to make it more soluble. So again, in some cases you have to use phenytoin IV. It's not preferred, but if you have a shortage of phosphenytoin. So for instance, we had to deal with this because again, we talked about pediatric drug administration, especially IV, is already tenuous to begin with. Their veins are much smaller than adult patients, and so this becomes more of an issue. We either had an issue where phosphenytoin went on shortage because they had some issue not with the drug itself, but actually the production of it, and they had pieces of glass particulate from the vials were in the solution of drugs, so they had to recall a bunch of them, and we had to go back to using regular phenytoin. Phenytoin's a pH, normal blood pH 7.35, 7.45. You have to make the pH of phenytoin up to like 11. So it's very basic, very irritating to the veins. Also, you have to put in things like ethylene glycol and propylene glycol, alcohol, all those other different things to make it go into solution. So it's not great, right? So that's why I like phosphate a lot better for IV administration. But it is going to be first line for a lot of different generalized and partial seizures, and then we'll talk about rash and Stevens-Johnson syndrome a little bit later on, but just know this is another one that can cause that. So for a lot of these drugs, if they're starting out a new antiepileptic, they notice a new rash, that is a warning sign. They need to really come and get checked out for that, especially if they have any kind of like blistering, skin sloughing, anything like that. That could be very, very bad for them. They need immediate attention for that. So again, I mentioned that dosing, and I'm not going to quiz you specifically on dosing, but just know that this is another drug because it has a relatively long half-life. You have to give loading doses. So this is another thing you'll see when you have a patient with an acute seizure. Is a lot of times for these drugs, you'll get a big loading dose, and then you'll get put on maintenance dosing afterwards. And remember, the loading dose does what for us? Gets you to steady state faster, right? So again, if you had a patient with having a seizure, you want to wait a couple days to weeks in order to get that level up to where it's actually being effective. You want that drug to be effective right now because they're having a seizure. So this is where loading doses can be very useful for that. And this is very important when you're dealing with a patient who, say, comes in for a seizure, who's already on treatment for it. So one of the things we'll ask, they come in, they're on phenytoin at home, they come in with a seizure. The question is, well, when's the last time you took a dose? Because again, compliance is really important. So they're like, oh, well, their family member says they haven't taken it in 2 weeks. Okay, well, I know they have no drug in the system. Let's go ahead and give them a loading dose, get them back up to their steady state, and they're good to go, right? Otherwise, they may come in and say, well, they took a dose this morning, so I know that, okay, they've been taking it pretty consistently per history. They probably don't need another big loading dose, because if I do, then their level gets way too high, and that can cause adverse reactions, right? So that could be leading you to think, well, maybe I'll just give a half dose of this, maybe I'll just use a different drug completely. These are things you have to consider when you're dealing with these patients, from especially for like an emergency medicine standpoint, right? We were talking about the drug, how the dose changed based on the weight and, the age of the child or the adult patient based on that metabolism there. And then looking at the levels we'll do, this is another one we'll actually do levels on, where, for instance, we'll look at things like total phenytoin versus free phenytoin. What do you think the difference is between these two?
The protein binding.
That's a protein binding effect right there. So again, I can look at a patient as a total phenytoin level of, say, 15, and they're coming in and they're super sedate, and they're not really able to, they're having lots of memory impairment, they just look like they're drunk. And like, well, that's weird because their level is within the therapeutic range. Why are they having these problems? Then I go in and measure the albumin. The albumin's low. Then I would say, okay, well, I know the albumin's low. I know they have a higher free fraction. If I went ahead and just did a free phenytoin level, you might see that it might be, say, 2.5 or 3, and that would be indicative of they have too high of a free fraction. That's why their levels that's why they're acting this way. That's why they're so sedate. It's because their free level, the active drug, is too high. That kind of makes sense. So again, it's one of those things where you may, it's easy to get a total phenytoin level, but the free ones, depending on where you work, they may not have it readily available. It may take a few days, but that can be very useful to try to identify why your patient's having their issues that they're having. So just know, and again, like, this is one of those things where it's kind of interesting. I'm not going to get into the details of the kinetics, but just know that small dose adjustments, especially kind of in the higher end of the dosing spectrum, can cause big changes in the half-life of the drug, because we exhaust the number of enzymes that are available to metabolize it. So we'll have some cases where patients can get too high of a level, and they're stuck for a week being super sedate and having fall risk and things like that because the level is just too high, and it takes the time for the liver to break it down. So just know you have to be careful with phenytoin and make sure you're doing small dose adjustments, because even for some patients, when they get to that certain threshold, once they go past that, then they just don't metabolize it very well. Okay. So I talked about the protein binding problems here. So again, other patients can have issues with this. They have a renal failure. That can be another reason they might hold on to too much drug there. Have issues with albumin. Other things can happen if you have multiple antiepileptics that are competing for those binding sites. If one of them kicks the other one off, that could be problematic there as well. So just be aware. Think about that protein binding. This is where free levels of phenytoin can be very useful for our purposes. Okay. That's phenytoin. Next one we have carbamazepine. This one you're going to commonly see being used for bipolar disorder. This is a very common one we use for as a mood stabilizer. It's kind of the broad term for that. But again, this is working as a sodium channel blocker. So very similar mechanism to what we see with phenytoin, at least for our purposes. And I mentioned this autoinduction of its own metabolism. What do you think that means? It's going to be important for the dosing we look at, but basically what this means is it induces enzymes, very similar to what we saw with phenytoin, but actually induces its own metabolism. So I can give the same dose of drug, we actually see the levels start to drop off lower and lower as those enzymes start to get upregulated. So this is why we'll look at the dosing spectrum here and why we see, or the dosing regimen, see how you actually start the patient off on one dose and say the next week you increase them to a next dose and the next week you increase them to another dose because of that induction of those enzymes. Because again, we know as you have more enzymes available, you're going to metabolize more of that drug and the levels go down. So just be aware, this induces 3A4, 2C9, 2C19. This is, again, very problematic as far as drug interactions go. Look up your interaction checkers before you prescribe these drugs, okay? And it could be more reasonable that you might prescribe one of these, especially from a behavioral health standpoint, right? So it may not be necessarily dealing with these neurology patients, but you're dealing with it from a behavioral health standpoint. Be careful with that. Again, a lot of sedation, dizziness, diplopia is very common with these sedative sort of drugs. And as far as monitoring goes, this is one we're going to be monitoring LFTs for, because again, a lot of these are hepatically metabolized. We want to monitor LFTs, make sure they're not having any issues with that. And then this one can actually cause some bone marrow suppression. So this is another one you might want to monitor CBCs for things like thrombocytopenia, leukopenia, etc. And then one other kind of unique thing with carbamazepine is this hyponatremia. You can see with that. And we mentioned that big electrolyte changes can cause seizures. So again, your patient comes in having a seizure. Is it because the carbamazepine is not working, or is it because their sodium's like 119 or something, right? So these are all the kind of things you have to consider when dealing with carbamazepine. So here's an example of that dose titration where you start off and say a 4 to 5 mg per kilo, but then you start to gradually increase that up to a kind of a maximal threshold. And this is to counteract that induction of its own metabolism that occurs with that one. So just kind of keep that in mind. This is another one we'll do therapeutic monitoring on. So again, I'm not going to have you memorize the levels, but just be aware that there are some of these that we do levels on, some of them we just don't do levels on due to lack of correlation between the actual level and what the therapeutic effect is going to be. Now, a cousin to carbamazepine is going to be another one called Oxcarbazepine. This one we cannot get levels on, even though the structure is very similar to carbamazepine, but it works very, very similarly. The only big thing you need to be careful for is that it's going to be more likely to cause hyponatremia. Now, have I mentioned SIADH before? That syndrome of inappropriate antidiuretic hormones, where basically you're sitting at too much vasopressin and you're holding on to too much water, and you get hyponatremia from that standpoint. So again, this one's more frequent with Oxcarbazepine. So if a question were to come up, say like, which of these antiepileptics were you most likely to monitor sodium for? Carbamazepine and Oxcarbazepine are the two big ones for that particular monitoring. But the other nice thing about Oxcarbazepine is there's fewer adverse drug reactions, fewer drug interactions that occur here than carbamazepine. So you may see some bipolar patients on Oxcarbazepine or on carbamazepine. Just depends on what the prescriber is most comfortable with and what they've kind of responded best to. Here's another very common one called valproic acid. Anyone ever heard of Depakote or Depakine before? This is another very common one for not only seizures, but also we see this as a very commonly used mood stabilizer for bipolar disorder. So a lot of we'll talk more about this in the behavioral health section, but valproic acid is a very common one. This one kind of has multiple mechanisms that this works by. So not only does it block sodium channels, but it will also inhibit calcium channels and can actually help to enhance GABA activity. So kind of more broad spectrum activity is why it's kind of useful for these different indications here. This is another one that can have a lot of protein binding, so you do have to be careful for that. If you do notice adverse effects and things like that, go back and look at the the albumin levels, make sure those are in the appropriate ranges there. We'll talk about side effects a little bit later on, but just be aware this one can cause pancreatitis. So if you ever go through pancreatitis, this is valproic acid is kind of one of those more common ones you think of with causing pancreatitis, and definitely some hepatotoxicity, thrombocytopenia, etc. Again, just watch those platelet activity. If they get thrombocytopenia, obviously avoid things like NSAIDs, adding on those. And this can also induce 2C9 and another enzyme system called UGT, which I'm not going to get too into detail on, but just know this can affect other drugs like Lamotrigine, which we'll talk about a little bit later on, Lorazepam, etc. In the therapeutic range, this is another one we'll do levels on to make sure they stay within that nice range. This one's kind of nice though, because valproic acid, the side effect profile is a lot more mild than what you see with some of these other drugs, and so you can go pretty far outside of that range in order to keep someone either from having seizures or to help control their mood. They have bipolar disorder, so I've seen people go up to like say 150 mics per ml, and they do just fine with that. So this one's pretty nice from a side effect profile. Okay. Now, benzodiazepines, we'll talk about this in the behavioral section. So this that'll be like the last section we'll talk about before the test. This is going to be most commonly used for acute treatment of seizures. So I'm sure most of you guys have heard of some of these, like diazepam or Valium is another brand name for that one. We have lorazepam, midazolam. Any of them can work. And if you remember, these basically work by helping to GABA to more readily bind to those channels to allow more chloride to flow in and cause cessation of those seizures. So there's just a couple smattering of different ones you may see being used. Diazepam is most commonly you see being used as a rectal gel. So imagine if you had someone who's having an acute seizure, a tonic-clonic seizure, they're on the floor, they're convulsing. How easy is it to give them an oral medication? You're not going to be able to, right? So this is where, very similar to how we give EpiPens to patients who have anaphylactic allergies, we give them Diastat, which is basically a similar device that's not an injection, but it's going to be, it'll have a tip on it that you will insert rectally, and you can actually administer the drug there. Because we know that the rectum is very vascularized, it's going to have very good drug absorption, and so that can help to stop a seizure. So it could be another common thing you see patients, they always carry it around with them, always have it available, so that way someone else, obviously they can't administer it themselves if they're having a seizure, but someone else can give it to them. This is why patient education is so important, and we do a lot of this education for our patients at Nemours, because we'll actually educate the parents on how to administer it, right? You may think like, okay, well, how hard is it to give a rectally administered drug? But if someone's having a seizure, you may not be in the right mindset. You may be kind of panicking a little bit. And so little things like applying, like it comes with like a lubricant packet, like doing things like applying a lubricant prior to applying it rectally. That's really important, because otherwise you can have rectal trauma and things like that. So education is super important to make sure they're administering it appropriately. There's lots of information's out there that can kind of help you with that education. So that's a very common one we see used on kind of the out of the hospital side of things. But other drugs we use a lot include things like lorazepam. So IV is most common for acute seizure management. So if you come into the ER with a seizure, you're probably going to get Ativan or lorazepam. Another very common one we're using nowadays is called midazolam or Versed as well. Again, they all work equally well for treating an acute seizure. Doesn't really matter which one you use. And this one's kind of interesting. IN stands for what? No.
Nasal.
Yeah, intranasal. So this is actually a good one we can use a lot, because again, if you're dealing with a patient, say you're working on EMS crew and you're responding to a patient who's having a seizure, how easy is it to start an IV on someone like that? Could be pretty difficult, right? Especially trying to, if they're convulsing, cannot get them to hold still. That can be very difficult to start an IV. So IM administration is very important, right? So we can do things like IM administration of midazolam. But a new thing we're starting to do more often now is going to be intranasal administration of it. So basically, you drop the dose. You have a little atomizing device that will cause a fine mist of drug to come out of the syringe. You just stick that in the air and apply that, and it works very similarly to intramuscular administration. So there's actually some studies out there. And that's something that, one, we can send home to our patients. So instead of having to use rectal drug, because again, getting them, someone having a seizure, getting their pants off and all that stuff can be problematic in some cases. So intranasal is a lot easier to administer in a lot of those situations. So that's something you may see. And then also with the EMS crew, so they'll start to use this as well. See, clonazepam is another common one that used a lot in pediatric seizures for more chronic maintenance to help prevent a seizure from occurring. And then another new one called clobazam or Onfi. This is one I'm starting to see a lot used in pediatric patients as well. Now, the main side effect here is going to be sedation. So this is not something that, if you can avoid having to use this chronically, that's going to be really good, because otherwise, if you think about a kid who's got a seizure disorder, they still have to go to school. They still have to go and learn things. And if you're sedated, like you're drunk, because again, this is working very similar to how ethanol works, that's not going to be super great for their quality of life there. So these are things we don't like them to have to be on it chronically, but occasionally may need to be on things like Klonopin for the long term. And of course, tolerance does develop to this, so you do get used to some of these sedative effects, but also withdrawal can be a problem here. So these are considered, and actually having withdrawal seizures is one of the big problems we run into. And so it's really important that they're taking these chronically. They need to titrate down off of it slowly to prevent some of these withdrawal type of effects. Okay. You guys remember what C4 means? These are controlled substances. That actually means that they're under more strict control than you see with like a lot of these other drugs. So I mentioned these because, again, there is abuse potential, very similar to how there's abuse potential to alcohol. People like the effect of these drugs. People like how they feel when they're taking them, and they may take them inappropriately. So this is why they're under C4. Remember, there's 5 different scales there. Do you remember what the most severe restriction is? Is it C5 or C1? Is it a hurricane scale or is it backwards? What is it? Yeah, so C1 is going to be the ones that have no accepted medical use. C2s are the ones you can actually still get from a pharmacy but have a lot of restrictions on them. C5 would be kind of the wimpiest ones. So these guys are not high up on the list here, but they're still considered a controlled substance. Still one of those things we have to make sure you're kind of following the appropriate laws as appropriate there. But anyway, for acute seizures, these are the go-to agents. This is the first drug you're going to get if you come into the ER with a seizure, probably some Ativan, where it helps stop that seizure, and then you can talk about other kind of maintenance meds afterwards. We'll talk more about that in the behavioral section as well, because we also use benzodiazepines commonly for what other condition? We don't necessarily use it to treat depression, but what kind of goes hand in hand with depression? Anxiety, so like panic attacks, things like that. So we see a lot of benzos being used for anxiety. Yeah. Okay, so next up we have our barbiturates. I'm only going to mention one or two here. So we have phenobarbital. If anyone ever comes up and asks for a refill on their peanut butter balls, this is probably what they're referring to. Patients say weird things. But this works very similar to the benzodiazepines, where they actually help these GABA channels to work better, more chloride flows in. These tend to be more sedating than you would see with the benzodiazepines, but they last a lot longer. So you might see these being used more for kind of chronic maintenance of seizures. But again, very, very sedating, very similar to alcohol. Again, some tolerances develop, but can have things like memory impairment, fall risk, all of that. These are also going to be C4s as well, so again, controlled substances. And actually, this is probably the go-to one used a lot for neonatal seizures. No particular good reason for that, then it's just what we've used for decades and decades. So if it's not broke, we don't like to fix it, right? This also gets metabolized by a lot of these CYP2C9, 3A4, 2C19, so you do have to be really careful for having these drug interactions. So again, run those checks before prescribing. And there's another one I'll actually do some therapeutic monitoring for. So 15 to 40 is usually a good range for a lot of those patients, but it can vary pretty greatly. So especially for patients with like really difficult to control seizures, especially those that aren't expected to have kind of a typical day-to-day sort of life. So you can think about someone who has like really severe anoxic brain injury. They may be bed bound. They may not be really expected to participate and like, go to things like school and whatnot. You can generally shoot for higher levels for those patients because again, we're not worried about them having a lot of like mental retention of things. We just want to prevent them from having a seizure. From them from having to come back to the hospital. So some patients run a little higher than that, but typically it's kind of a good range for most patients. Okay, another kind of miscellaneous one that's called Ethosuximide. This is the only one I'm going to have you remember. This is for a very particular type of seizure, and this is the drug of choice for absence seizures. For whatever reason, when I was in pharm school, our teacher for antiepileptics made us memorize this, and so I always remembered it. I'm going to make sure you guys remember it too, because again, you don't want to give the wrong drug to these patients, otherwise it's not going to be all that effective. So ethosuximide only used for absence seizures, and similarly, you don't want to use ethosuximide for other seizures, not really going to be all that effective. Works as a calcium channel blocker, but not really useful for anything else. Very few adverse side effects, so it's pretty well tolerated, but again, think absence seizure, think ethosuximide. Anyone ever heard of Neurontin, or actually I probably should have corrected that. This should be Lyrica on here, but anyone ever heard of Gabapentin or Pregabalin? Where do we use these a lot? Good to think about. Yeah, so neuropathies are going to be a big one. So think about like fibromyalgia, diabetic neuropathies. This is where you're starting to see some of these being used for neuropathic pain, and these are kind of the poster children for that. So it's kind of interesting. Even though these are structurally related to GABA, we actually think they're working more with these calcium channels, and they may help to increase GABA synthesis here. And so these are unique because they don't have a lot of drug interactions from a hepatic standpoint, because most of these are going to be renally eliminated, but you do have to watch renal function, otherwise they can hold on to it. Again, working very similar to GABA, they're going to cause a lot of sedative sort of effects. That's the other thing to kind of watch out for these drugs. What's kind of interesting is gabapentin itself is not a controlled substance, but pregabalin is for whatever reason. So I guess there's some clinical studies, and they found some people reported euphoria while taking pregabalin. So they said, well, that's got to be a controlled substance. So I believe this one's a C5, but gabapentin is not controlled. So kind of a weird thing you'll see with some of these drugs because they are so similar. But you can keep in mind, even though they may not have drug interactions from a metabolism standpoint, they can still have pharmacodynamic interactions with other anti-seizure drugs. So again, if I have two drugs and cause sedation individually and add them together, you see some synergistic sedation that happens there. So you can be careful with that. Okay. Up next, we have Lamotrigine or Lamictal. This is another one you may see being used for bipolar disorder. This one is going to be primarily working on blocking sodium channels and also will inhibit glutamate release. So kind of dual mechanism here. Prevents glutamate release. They can interact with those type of receptors and also blocks the sodium channels. This one's kind of interesting because it can actually have its metabolism inhibited by valproic acid, or it can be induced by other drugs like phenytoin or carbamazepine. So you have to be careful with this one because of some of the side effects we'll look at. And so when you think of lamotrigine, you want to think dermatologic reactions as being one of the more common serious side effects you can see with these drugs. And so some will inhibit its metabolism, some will induce. You need to look up these interactions beforehand. And so because of that rash that can occur here, it can lead to things like Stevens-Johnson syndrome, which I'll talk about briefly a little bit later on. But just be aware this is a very severe one. If you see new onset rash, patient needs to stop taking it, needs to come get checked out and make sure either need to change the dose or change the interactions happening or whatever happens to be, or maybe just switch off the drug completely. So just, kind of an example of, if you have an enzyme-inducing drug, you may start, say, only 50 milligrams of lamotrigine, but bump that dose up because you have an inducer on board, versus if you have an enzyme-inhibiting drug, you want to drop the levels of lamotrigine because those will be elevated by having the enzyme inhibitor on board. So you have to make sure you're watching your drug dosing, and this is where you'll find things like these in Lexicomp. Like that information's already out there. This is kind of a really good kind of standard go-to sort of anti-epileptics gaining popularity nowadays. This one's called Levetiracetam or Keppra. Most people just call it Keppra. This one we don't have a full idea of the mechanism. May have some interaction with calcium channels, but we just know it works. And it's quickly becoming the first line of therapy because it's you can get very, very big doses, not see a ton of side effects from it, really no drug interactions, so to speak, besides maybe some synergistic sedation with other drugs, but it works very, very well. And so we use it very frequently. We're starting to use it more for acute treatment of seizures. So say, for instance, someone has status epilepticus and they're not responding to a benzodiazepine like Ativan, we can give them Keppra as a backup. Whereas previously we go with things like Phenytoin as a backup. Nowadays, Keppra is becoming more and more commonly used here, especially if the patients were on it prior to whether they're being maintained on it outside of the hospital. We'll use this as a bolus in order to eliminate those seizures. The only kind of unique side effect you may see with this one is this increased aggression, and this is seen more with children. No real good reason for why this occurs. We just know that it is a side effect that is characteristic of Keppra. Next up we have Topamax. This one is another one that has kind of multiple mechanisms here, some sodium channel blockade, some enhanced GABA activity. It also interacts with glutamate receptors. And I mentioned this one gets used for a lot of off-label uses, so you'll see it used a lot for migraine prevention. I'll talk about migraines, I believe, in the next section, and then also sometimes for weight loss, because you see a little bit of weight loss with these drugs. Just be aware that you can see some additional benefit from this carbonic anhydrase activity. So you can actually either see renal calculi that can form from this due to monkeying around with the pH in the urine, or in some cases you may see some mild acidosis that happens there. Could be beneficial for your patient, but may not be for others. So just kind of keep that in mind. Okay, so those are the main drugs you're going to run into. There are many more that are out there, but I want to focus on kind of the more common ones. There's lots of new ones that are coming out that again, we don't have a ton of history with, we don't have a ton of experience with. This will probably become ever expanding list as I kind of continue teaching this course years and years, unless you guys get me fired. But it's one of those things. These are the main ones you're going to run into, probably on rotations, so just be aware of these. Now, as far as status epilepticus goes, and I mentioned these are kind of recurrent seizures where the patient does not return back to their baseline mental status. Again, this is an emergent condition, very similar to what you see with an anaphylactic reaction or status asthmaticus or anything like that. You have to treat it as an emergency. So obviously, the immediate thing you want to take care of, the patient comes rolling into the ER, is what? Airway, breathing, circulation. So ABCs are always going to be most important. So in some cases, these patients are not breathing appropriately on their own, right? Because they're actively seizing, so you may need to intubate them in a lot of cases. The nice thing, if we talk about intubation, we'll talk about sedatives that you give there. A lot of those sedatives can actually be used to treat the seizures, so that's kind of an additional benefit there. But make sure they're breathing, protect their airway, because again, a lot of times they could have vomited, might be aspirating fluid. You want to make sure you remove any kind of potential obstructions there. But once you actually get into the drug therapy, benzodiazepine is always going to be your go-to drug. So in a lot of cases, we use lorazepam or Ativan. It's the brand name. They use this one most commonly. But in some cases, they may have gotten diazepam, say, outside of the hospital. If they had a diastat, they're carrying that with them. They may have gotten that rectally, or they might have gotten something like Versed intranasally. Again, if you have IV access, lorazepam is the one to go with, but these may be available if IV access is not available or if not easily obtained. And that's really important to make sure that when you're dealing with like the EMS crew who's bringing the patient in, ask them what they already got outside of that. Because again, if they're not responding to something they've already received, you may want to switch it up and try something different. Okay, or you want to see how many doses of a drug they've already gotten, etc. Now, if they're unresponsive to that, that's when we're going to go over to something else. So we're going to kind of go by escalating stepwise approach to this therapy. So if the benzos are not working, then we're going to move on to something like phenytoin or primarily phosphenytoin. It's going to be a better IV agent to give mainly due to the solubility characteristics there. That can be very useful there. You may not. This is where it kind of gets a little bit more ambiguous. May not always go with phenytoin. Just depends on the neurologist. Depends on who the ER doc is. Depends on what they were on previously. Some cases you may go with like Keppra, or that Levetiracetam in this case. Sometimes you may go with Phenobarbital, and actually with neonates we'll probably go primarily with Phenobarbital for them. That's kind of the go-to drug for those patients. And then again, you're trying different drugs, seeing how they're responding, and if these are not working, you kind of keep going up the ladder there, where you have things like valproic acid may potentially be used, phenobarbital can be used, and then eventually you may just get to the point where you have to like kind of put them under general anesthesia or what we call pentobarbital coma. Pentobarb is just another type of barbiturate. Think of it like phenobarb, but we really only use it in very rare cases, such as this. So the takeaway is really ABCs up front, give benzos as your primary first-line drug, and then that's not working, then you're going to move on to something else. Phenytoin is very common, but it's not to say you wouldn't use something like valproic acid or Keppra. A lot of it becomes more ambiguous based on the patient, based on the providers that are working with them. That kind of makes sense? Okay. Sounds like easy and straightforward as like anaphylaxis, where it's like, okay, you give epi, and then you're going to give your Benadryl, and you're going to give your steroids, and but this one's going to be a little bit more kind of nebulous based on a lot of factors. But benzos are always going to be the first line go-to drug. Okay, so if you have a patient who is not really getting the proper effect out of a drug, or maybe the side effects are too intolerable, it's important to look for a drug maybe with a different mechanism to try to see if that's going to be more tolerable to them. The main thing we want to do here is to avoid toxicities from having two drugs on board at the same time, and to also avoid breakthrough seizures. Because again, you don't want the levels to get too high, cause toxicity, but you don't want the levels to drop too low, because that's when they can have a seizure occur there. So it's kind of a delicate balancing act that can happen here. So again, you generally what are going to do is kind of to titrate down off of one drug as you start another drug at a very low dose, and then gently titrate that one up. And ideally, you'd avoid a lot of those side effects, but primarily when you focus on a different mechanism, hopefully it will work a little bit better for your patient. Now, can you ever stop antiepileptic therapy? Occasionally you can. Depends if they've been seizure-free for a number of years. They only have one single seizure type typically. And again, this can be different for every patient. But typically we're looking for kind of normal neurological exams. So again, no structural brain issues. And they have kind of normalized EEG with treatment. So those are kind of some of the things you're going to look for to deciding whether to stop. A lot of patients may not be able to, and they just may be on lifetime therapy. So it just depends on the patient. Okay. Be aware when you're doing drug levels, just to look for, kind of know beforehand, what are you trying to look for? You're looking for efficacy to see if the drug's in the right level. That's one thing you can look for. You could also be looking for safety purposes. So if the patient is having adverse drug reactions, and you're like, okay, well, what's the level doing? That can kind of help guide you to see whether you should change your dose or not based on that. But make sure you're looking at a steady state level. If you look at your levels too early and you're prior to steady state, that's problematic because, again, your levels may look falsely low, and you may try to increase your dose when you don't really need to, and the patient comes back with a level way too high later on. So watch out for that. Again, remember those drug interactions we talked about, and other disease states, like especially hepatic impairment can really be important here, but also for some of them, like Gabapentin, things like that, renal function can be important to monitor for as well. And make sure if you have a patient who comes back with a level that looks a little too high or too low, but they've been seizure-free, they're not having any problems, you don't necessarily need to follow that level. All right? Remember, always treat the patient first, not the level. Okay, so as far as adverse reactions, we're going to go a little bit more into detail on these. The CNS effects are going to be the primary thing. This can range anywhere from just simple drowsiness to you can have some, as antiepileptic levels rise, you can see seizures that can actually occur for some of these. So just be aware, if the patient's having kind of excessive sedation, things like valproic acid and Lamotrigine tend to be a little bit better on this, so that may be a little bit less drowsy to them. But again, Phenobarbital tends to be very, very sedating. We like to avoid those in like school-age kids, things like that, where they're kind of actively learning, they need good memory. Just note with Keppra, remember we talked about those that increased aggression. Some patients even exhibited things like psychosis and suicide attempts as one thing that is rare, but at least to be aware of, right? Educate your patients on. Otherwise, Keppra is like water. You can give as much Keppra as you want. It's very, very effective and very safe. But just some patients are going to be more predisposed to that. And again, just keep in mind, some patients may develop kind of hallucinations, may some have anxiety, depression associated with their antiepileptic drugs. It's important to monitor these things, try to get a good baseline and kind of monitor them as the months go on and see how they're responding to it. Make sure they don't have any issues. Could lead you to want to go ahead and switch to a different type of drug altogether. And as far as dermatologic reaction, we talked about Stevens-Johnson syndrome. This is a very severe reaction where you're having a lot of skin blistering, skin sloughing off. Can be potentially fatal if not caught early and treated with aggressive supportive care. Big ones that are more likely to cause this include things like Carbamazepine, Ethosuximide, Phenytoin, and then Phenobarb. Somewhat rarely, I actually had one patient who was on, it's kind of interesting because the patient was on Lamotrigine and they were on, I believe, Carbamazepine as well. And the patient was getting admitted for Stevens-Johnson syndrome, so they stopped the Lamotrigine, but they kept the Carbamazepine going. And so one of the things where I was like, hey, well, you know, Carbamazepine can also do it as well. And so it's one of those things where if you have two drugs on board, you don't know which one was the causative agent, right? So it's one of those things where you have to kind of stop both and start up something else to see how they respond to it. Again, Oxcarbazepine and Lamotrigine are the primary offenders here as far as rashes, life-threatening rashes go. So be very careful. If a patient has any kind of skin issues with these, make sure they stop, come into an ER, get checked out, and then get switched over to something else. Yes, ma'am.
Would you be titrating these down if they came with this reaction?
If they came up with this reaction, it would be something where I would just stop them completely. Because again, if you think about this, they're going to be admitted, right? They're going to be on the inpatient side. They'll have standing orders for things like, you know, Ativan, PRN seizures, right? So we have means to treat them pretty effectively. So we can stop the drug, let it get out of the system, let their skin kind of recuperate, and then we have other things we can use. That's a good question. And as far as hematologic stuff goes, you want to monitor their CBCs for things like granulocytosis, leukopenia, thrombocytopenia. More commonly seen with things like carbamazepine, valproic acid, and phenytoin. Again, other things to look for as far as to let the patient know to monitor for. You know, if they're having abnormal bleeding, any kind of mouth ulcers, things like that, it could be indicative of some sort of blood dyscrasia. Let them know to come and get checked out. As far as hepatologic problems here, you can see hepatitis develop with some of these drugs. You can see hepatic failure rarely. So again, if the patient already has hepatic problems to begin with, you know, these are some drugs you may want to avoid and move to something that may be more primarily renally eliminated. But again, carbamazepine, phenytoin, and valproic acid are kind of notorious for this. And the valproic acid itself, you know, you can see it occur early on in therapy, but sometimes it takes several months for this kind of to develop. So be careful, especially if they're receiving multiple of these drugs. You can see some synergism there, so you'll be careful with that. Okay, so again, as far as the drowsiness goes, again, make sure you're monitoring their dosage, try to monitor and titrate that as appropriately. In some cases, you may find that patients can help to get around sedation by kind of restructuring when they're getting their drugs. So for instance, if they get really sedate, you may move it over more to like a nighttime administration. That can help them to kind of sleep through that. They wake up, they might be a little bit more kind of ready to face the day. And always like to switch to monotherapy whenever possible. Fewer drugs are better. And then if we can use less sedating antiepileptic drugs, that's always going to be better for them. Yes. It depends. A lot of them come as extended release preparations that will help you to achieve either once or twice daily dosing. But for things like, you know, phenytoin, that could be a 3 times daily drug. You know, gabapentin is usually 3 times daily. So we like to use fewer administrations. You're absolutely correct, but sometimes you can't get around that. So things like Keppra, especially, that's a twice daily drug. Can't really get away from that one. Yeah, so it just depends on the patient and what the drug is. So again, as far as monitoring goes, you're going to be looking for that seizure control. So again, are they having seizures? Because that could be indicative of either the drug not working, levels are not high enough, could be other things going on there. We'll monitor drug levels if they're applicable. If I didn't mention it here, chances are we don't have really good levels to monitor for. So I'll have docs who will be like, well, I want to get a Lamictal level, a Lamotrigine level. And I'm like, well, you can get the level, you can send it off, and it costs a lot of money. It takes a couple weeks to come back. But then what are you going to do with that level? because we don't have any established ranges to say like, well, this is effective and this is toxic or this is too low. It could be useful if you're trying to see if the patient's compliant, because obviously the patient says, I'm taking it every day, comes back 0. That's pretty indicative of them, not taking it. But other than that, it may not be super useful. It may just add increased cost when they doesn't really get any additional benefit out of that. And then we talked about the monitoring. You remember what we're looking at sodium for? Yeah, so remember like carbamazepine, oxcarbazepine are the 2 big ones. You're going to monitor sodium for those. So again, monitoring needs to be appropriate based on the drug you're using. Mentioned therapy drug monitoring for a couple of these drugs. Again, a lot of the other ones, as I mentioned, don't have a good correlation between the drug level and what actual therapeutic range is going to be. So that's why we don't really like to order them that often. As far as drug interactions go, you need to look to see whether they're inducers, whether they're inhibitors. Just be aware that these are out there. They can affect a lot of the other drugs they may be on. So if they have diabetes or hypertension, all these other things can be affected as well. So you have to run those interaction reports just to find out. Even if you're 99% sure, just run the interaction checker anyway. It takes you 5 seconds, and you can potentially avoid a pretty serious drug interaction. The other thing to consider, a lot of these drugs are teratogenic. I didn't mention this specifically, but a lot of these drugs, you do not want your patients getting pregnant while on them because they can cause very severe birth defects in the fetus. Especially things like valproic acid is notorious for causing neural tube defects and other big issues there. So one of the things you have to consider is like, okay, well, I don't want my teenage female patient to get pregnant. They should probably be on oral contraceptives at the same time, right? If they're sexually active. So you have to be careful with that because actually some of these drugs can increase the metabolism, can induce those enzymes, and actually make their oral contraceptives less effective. They need to be aware of that because, again, if they're going to have these levels of contraceptives drop, they need to use a backup method because, again, we don't want failure of those therapies because otherwise it could have unwanted pregnancy, and that's no good, right? Even if you did want the pregnancy and then once they're born, you may be like, is this such a good idea? And ultimately, yes, it is a good idea, even if even if you haven't slept much, but that's okay. I'm just kidding. I love my 2 children that I know of. Anyway, so good ones that do not interact are going to be primarily the ones that get renally eliminated. So that's kind of a good safe thing to consider. But things like Gabapentin, Levetiracetam, Lamotrigine, these are good ones that don't have a lot of specific inducing interactions, and this is going to help those levels to stay right where they need to be to hopefully prevent any kind of pregnancies from occurring. Okay, so any questions on that section? We're not done yet, so don't pack up your stuff yet.
So what would you do for a patient who wanted to get pregnant? There are no options.
That's tough. That is a good question because you try to find one that has the least. Again, I'm not an expert on this particular case, but I imagine what you need to do is one, try to find the least offensive drug possible, which I don't really know there's any super good ones from that standpoint. You also have to look at if they have really bad uncontrolled seizures, like maybe that's just not appropriate for them. It's a conversation you have to have, and honestly, I would talk to neurologists. They might have some good experience with that. I don't know if there's any good guidelines though out there, but that's maybe a good thing to search for and see. But that's a good question, a difficult question to say the least. Yeah, because again, a lot of these drugs are super nasty from the teratogenic standpoint. You definitely a lot of them are either category D or X. A lot of cases, yeah, so it's something to watch out for. Okay, so briefly, we're going to cover Alzheimer's disease. Don't forget about this, right? Just kidding. Okay, what is Alzheimer's disease? Anyone know? Yeah, you see, there's a lot of breakdown of the brain tissues, a lot of morphological changes that occur here. But if you had to describe it to somebody, what would you say?
What did you say?
If you had to describe Alzheimer's disease to a layperson, how would you describe it?
Memory issues,
Yeah, a lot of memory issues, having a lot of memory loss is occurring here. So again, yeah, so they're going to have basically it's a progressive degradation of their memory essentially, right? So again, it can be as easy as like, oh, I forgot where I left my keys, which I'm sure a lot of people have kind of momentary lapses like that, but it can be so severe to like one, they don't remember who they are or who their loved ones are. They don't remember where they're at. They cannot perform a lot of activities of daily living. This is one of the primary things you see a lot of like institutionalization of a lot of these elderly patients. And again, primarily it's going to be affecting elderly patients. But this is a huge, huge deal. And I don't know if anyone's ever dealt with Alzheimer's disease and a family member. It's pretty awful. Like my my grandparents were married, I think, for like 60 some odd years, which I think is pretty good accomplishment. Grandpa passed away, and then within a year or two, my grandma's Alzheimer's just went rampant, you know, and it's terrible because like they just don't know what they're doing. They can't really control themselves very well anymore, and it's a pretty severe disease. So we unfortunately don't have a lot of good pharmacotherapy. We'll talk about a little bit of it here, but again, it's one of those things where like early recognition is super important, and a lot of the non-pharmacologic therapy is very, very important for these patients. But anywho, these are some of the things you can see. You see these plaques kind of form. That's kind of that Swiss cheese kind of look that you can see on the brain that occurs. But again, these different types of proteins that start to form here, and basically just degradation of the brain tissue over time, right? So there are a couple of different kind of theories on some of the issues that are happening with these Alzheimer's patients, kind of what's happening with the different neurons. There's one with this cholinergic neurotransmission therapy we're going to talk about. And so basically, we believe in Alzheimer's disease, you're losing some of these cholinergic neurons. And of course, cholinergic neurons are releasing what neurotransmitter? Acetylcholinesterase. That's the primary thing we're going to be looking at here. And by losing these neurons, we're losing some of that decline in memory and also cognition, right? So by having further degradation of these neurons, they're releasing less acetylcholine out into the synapse, and then you're not really having these connections being made here between the neurons. That's what's leading to some of the memory loss. Now, anyone remember how acetylcholine gets metabolized? Acetylcholinesterase, right? Acetylcholinesterase will come in and break it down. Cholinesterase will break it down into choline and acetyl-CoA, and then it can get reuptaken into the neuron, and then it can be formed again to be released into that. And so again, the brain likes to be likes to recycle, likes to be able to use things again, likes to be pretty cost conscious from that standpoint. So this recycling process is a very common one. The thing we can try to do, though, is if we can try to keep more acetylcholine around, because we know the neurons are not sending out as much, let's try to keep more in the synapse. And so this is where we're going to see our primary use of drugs here is going to be our cholinesterase inhibitors. We have a few that are going to be useful for this. So again, if you imagine a normal brain kind of releasing acetylcholine onto these neurons, cholinesterase breaking down to choline where it can be recycled, versus if we're breaking down these neurons here, they're not going to be able to release as much acetylcholine. The idea here is by giving a cholinesterase inhibitor, you keep more acetylcholine in the synapse, better memory, less memory impairment occurring, hopefully helping to reduce some of those symptoms. So some things to consider when using a cholinesterase inhibitor. We mentioned that you want things that are going to be specific for working up in the brain, because if I affect acetylcholine throughout the body, what type of side effects could you expect to see? So remember, acetylcholine is really important for which nervous system? Sympathetic or parasympathetic? Actually important for both, but primarily when we're looking at actual like physical effects. Parasympathetic, right? It's your rest and digest nervous system. If you have too much activity of those muscarinic receptors, you see a lot of side effects associated with that, right? So you see things like defecation, urination, meiosis. We talked about that, the dumbbells as being the primary muscarinic side effects you can see from blocking the activity of acetylcholinesterase. So you want things that are going to have activity up in the brain to help increase the acetylcholine levels, but you don't want them to kind of act everywhere else. And so that's one of the problems you ran into with a lot of early drugs we used for this. They want to have high enzyme specificity. The other thing is a lot of drugs have problems crossing that blood-brain barrier. They don't get across into the brain, guess what? Not going to be super useful. So we also have to have drugs that can actually cross that very well. And then I mentioned the cholinergic toxidrome here, the side effects. So again, that defecation, urination, meiosis, that bradycardia, bronchuria, bronchospasm, emesis, lacrimation, and salivation. So again, even in mild cases, because older patients, they have issues with incontinence, they have other problems where this could be a big impact on their quality of life. So you have to be careful with that. And this is one of those things you'll see with these drugs. So the cholinesterase inhibitors we like to use are centrally acting, and they're going to be better for more mild to moderate Alzheimer's disease, right? So this is not going to be super useful in the very severe disease because, again, if most of those neurons are destroyed, they're not going to be releasing a lot of acetylcholine in the first place. So this helps to improve memory and cognition, but unfortunately does not really affect further neuronal degradation. We'll find one drug that may potentially help out with that, but does not help to slow down the disease progression. It just helps with some of the symptomatic management. So it's important to remember. So the three ones we're going to deal with most frequently are going to include donepezil, rivastigmine, and galantamine. Probably donepezil is probably the most common one I've seen being used here. As far as kinetics go, don't really get too hung up on these. Just know that the longer the half-life is, the more likely it is to require less frequent dosing, which is important, right? Because again, if you have Alzheimer's disease, you forget to take your medications, right? So that can be an important thing. Some of these are going to be available as a patch, which can be very useful, especially if you're only having to give the patch, like say every 7 days or so. A caregiver can be kind of very useful to remember to put that on. Replacing it in a week. It's a lot easier as far as compliance goes for some of these patients. But just know that we don't really like this Tacron anymore. This is kind of the first one we have. It had very severe side effects. Nowadays, we have a lot more kind of preferentially acting, more centrally acting drugs that kind of limit a lot of those kind of peripheral side effects we mentioned in the last slide there. So, donepezil or Aricept, again, high plasma protein binding and a long half-life, so that helps with only having once daily dosing, so that way it sticks around for a good period of time. You don't have to have multiple doses throughout the day. So again, very nice there. Again, you don't have a lot of these drugs actually inducing or inhibiting CYP enzymes, but they may be affected by other drugs that affect that, right? So again, if they're on an antiepileptic drug that affected CYP3A4, it could affect these drugs as well. So just keep those interactions in mind. We have rivastigmine or Exelon. This one has a relatively short half-life, only saying in an hour to 90 minutes or so. But this actually binds much more tightly. It covalently binds to cholinesterase. So because of that, it doesn't dissociate very well, and so it sticks around for longer. So again, the half-life is a little bit misleading. You think about how often you have to give this drug. This one you get away with like twice daily dosing. Not ideal, but could still be useful for some patients. And then galantamine or Razidine, again, this one is going to be a twice daily dosing one. This one has a moderate half-life here, but doesn't have that same kind of really good covalent kind of slow dissociation with the enzyme like you saw with the last one there. Okay, so nothing other too interesting with those. Right. So those are the cholinesterase inhibiting drugs, right? So remember, those three are going to be the primary ones we're going to be looking at to help with those kind of mild to moderate symptoms. The other side of things is like, why do these neurons start to degrade in the first place? And so some people think that glutamate can be really important here. We mentioned glutamate is excitatory, and if you have too much glutamate activity on a neuron, too much excitation can actually lead to destruction of the neuron over time, kind of this excitotoxicity that occurs. There's a term for that, excuse me. But basically what we're seeing is that you have too much excitotoxicity, you degrade those neurons. So if we could do something to block glutamate, this could actually be useful to help prevent further degradation. So this is a group of drugs, or a drug, that can hopefully slow down the progression of disease rather than just treating the symptoms of it. So the drug we have for that is called memantine or Namenda, and basically this is an NMDA receptor antagonist. So even though I say ketamine is another drug that does this, it doesn't really have the same kind of psychedelic effects as you would see with ketamine. But basically, by blocking glutamate, these NMDA receptors, you try to decrease that excitotoxicity and preserve those acetylcholine-releasing neurons as best you can. This helps with not only cognitive function, but helps them to retain their daily activities like bathing and getting around, things like that. And again, it's pretty well tolerated. So this is another thing that can help slow progression and also treat some of those symptoms. In addition to the cholinesterase inhibitors are mainly just going to be for symptomatic management. So you can imagine here a glutamate presynaptic neuron. By having memantine just blocking this receptor here, again, you're going to have less calcium influx into the cell, less excitotoxicity happening there. And this one's good. Again, single daily dose due to kind of a long half-life there. So again, good for good for those kind of memory impairment where it's already kind of set in, and compliance is a bit of an issue. But again, this is not going to help correct someone's Alzheimer's disease. It's not going to reverse anything, but hopefully we'll slow it down to some degree. Okay, so that's it for this section. Not a lot of drugs for Alzheimer's disease. Unfortunately, I wish we had some better therapies out there, but hopefully we'll develop something down the road and hopefully cure it. That'd be wonderful. But anyway, any questions I can answer for you guys on anti-epileptic drugs or Alzheimer's? Next week we'll do Parkinson's and I believe migraines and headaches, things like that. Give you guys enough headaches. It's about time you learn how to treat them yourselves, right? All right, well, take your extra 10 minutes, enjoy them, and I'll see you guys next week.